Hello, good morning, everyone. Ready? Shall we start? We'll quickly discuss today about the local anesthetics and regional anesthesia. Other than the pre-anesthetic checkup and monitoring and airway equipment, the next most commonly asked questions are from local anesthetics and regional anesthesia, particularly. Okay, the important topics are, if you see in the last 5 years, it is from bupivacaine, and more particularly, even in the last INI-CET examination, there's a question on bupivacaine toxicity. I mean, the MLAW and local anesthetic toxicity are important. Okay, if you see here, we'll discuss a little fast. The local anesthetics are broadly divided into ester group and amide group. How do you identify? Ester group has one eye and amide group has two eyes. And metabolism in ester group is through plasma pseudocholinesterase, with the exception of cocaine, which has metabolism in the liver. But for amide group, the metabolism is in the liver by liver amidases. Exception for prilocaine, it has all extrahepatic metabolism also. It has both lung and also it happens in liver. And ester group, there is a high incidence of allergic reaction. Amide group, there are low incidence of allergic reactions. And ester group are unstable solutions and amide group are stable solutions. When I mention one eye, it is procaine, cocaine, benzocaine, chlorprocaine, and here two eyes: lidocaine, bupivacaine, prilocaine, etidocaine, ropivacaine, mepivacaine, dibucaine. The only exception here is you have to remember is xylocaine. Though it has only one eye, xylocaine is nothing but it is a lignocaine without a preservative. Okay, lidocaine without preservative is called as xylocaine. We will discuss about this when we are discussing about the lignocaine per se. And there have been the duration and potency. If they are shorter acting, they have a less potency. Intermediate acting, intermediate potency, and long acting usually have a most potent. You have to remember which of them is the shortest acting. Chlorprocaine is the shortest acting. Chlorprocaine is the shortest acting. And another thing is procaine. Cocaine, and long acting are benzocaine and tetrocaine. Among amide group of local anesthetic, nothing to remember about short acting. Intermediate acting, remember LMP, mepivacaine, prilocaine. Rest all are under comes under long acting, and you have to remember one thing, that is dibucaine. It is the longest acting local anesthetic. The rest all, whatever it may be, etidocaine, you can, all these things are long acting. But you have to remember it is chlorprocaine and dibucaine. Very, very important. If you get a question saying all of the which of the following has duration of action more than 2 hours, then you'll remember among the ester group there is benzocaine, tetrocaine, and among amides except lignocaine, mepivacaine, prilocaine, everything. Okay, this is all about. Then mechanism of action, very simple. Once you give a drug at the local site, the unionized form of the drugs enters inside into the exoplasm. The local anesthetic becomes ionized and blocks the channel from inside. Okay, predominant action is with the sodium channels and block sodium potassium ATPase. It also acts on calcium channels, potassium channels, and even NMDA receptors. So what happens? Unionized form enters inside to become ionized and blocks the channel from inside. Clear? If they ask what is the sequence of blockade, see, thin fibers and myelinated fibers are more sensitive. If they ask which is the sensitivity of local anesthetic, which is more for, then it is A more than, B more than, C. If they ask specifically, which is the most common one among the sensitivity of local anesthetics, if they ask specifically among gamma, delta, alpha, beta, which has more sensitivity? Come on, type in the chat box, guys. It is A gamma followed by A delta followed by A alpha equal to A beta more than B more than C. Okay, please remember this. A gamma followed by delta B and C. Then if you ask among central neuraxial blockade and peripheral neuraxial blockade, central neuraxial blockade means you're giving the drug and the spine for spinal anesthesia, and peripheral neuraxial blockade means giving and the local anesthetic you're administering over the peripheral nerves. So among motor, sensory, and autonomic, which is going to involve more, remember here in central neuraxial blockade, first autonomic will be blocked first, then sensory, then motor. The reverse here. Motor, sensory, and autonomic. And among the sensations like pain, temperature, touch, pressure, proprioception, which is the first one to get involved, first one to get sensitized with blocked. In peripheral neuraxial blockade, it is pain, followed by temperature, followed by touch, then pressure, then proprioception. The same thing here, it is exactly opposite. It is first temperature, pain, then touch, pressure, and proprioception. Okay, I remember. P for P. In peripheral neuraxial blockade, pain is the first sensation get involved. Clear? Then coming to pharmacokinetics. See, whenever you give a drug, how fast it acts and how effectively it acts depend on pharmacokinetics, how actually it absorbs and what is the dose you are giving, have you added any vasoconstrictor. Absorption, it basically depends on the dosage, site of injection, and addition of vasoconstrictor. Site of injection, if it is more vascularity, leads to faster absorption into the systemic circulation. So if we give a drug at the level of on the face, it absorbs faster and its duration of action is also less because it absorbs into the central circulation faster. If you see the peak plasma concentration of a single dose of local anesthetic, when you give an IV, it will be more, followed by intrapleural, intercostal, brachial plexus, epidural, and sciatic. For you, like, even if you forget all the sequence, remember one thing very easily. Wherever is the site, if it is more vascular, it has more absorption when compared with less vascular. Easy to remember. Okay, dose. Similarly, if you give more dose, more effect. As simple as that. No one is going to ask you a question based on that. Then remember, addition of vasoconstrictor, what happens? It decreases the local blood flow. Once it decreases the local blood flow, it decreases the systemic absorption, and it helps in for the local anesthetic drug to be present in the site for a prolonged duration, for more time, causing increased duration of action. So addition of vasoconstrictor is very important because the increased duration of action. So what are the drugs we use? Adrenaline and phenylephrine. Adrenaline we use in a concentration of 1:2 lakh. Phenylephrine 1:20,000. And local anesthetic with vasoconstriction is contraindicated in conditions of end arteries. So in conditions of examples, come on, type in the chat box, guys. Finger block, penile block, end arteries, all these sites, you should not give, you should not add vasoconstrictor. And as we already discussed, metabolism, esters are by esterases, amides by liver amidases. This is plasma cholinesterases, to be very precise. The esterases are plasma cholinesterases. Okay, so what is the exception here? Cocaine, which has in liver. Here the exception is prilocaine, which has liver and also it has in lung. Clear? Then Coming to onset of action, again depends upon the dose, concentration, and type of nerve fiber, pKa, addition of sodium bicarbonate. Remember, pKa, it depends, it has pharmacological profile of the drug. pKa represents the pharmacological profile of the drug. If it is closer to pKa, the pH of drug, if it is closer to pKa, it has faster action. So what happens if you add one more important question, addition of sodium bicarbonate? Addition of sodium bicarbonate, what happens? It increases the speed of onset, improves the quality of the block. Rapid onset, and also it improves the quality of the block. This particularly you have to remember about the addition of soda bicarbonate. Then coming to the individual drugs. Who used cocaine first? Cocaine was first used by and where? Very good. Cocaine was first used by Carl Culler. First local anesthetic used for topical anesthesia. And it is ester which is not metabolized by esterases. Metabolism by liver amidases. It can't be given IV because of its metabolite and because it may cause ventricular fibrillations. And it has its metabolite ecognin, which stimulates sympathetic system and CNS. Again, what are the side effects of cocaine? Come on, guys. What are the side effects of cocaine? It even cause vasoconstriction and ventricular fibrillations and seizures. Because of its ecognin, it causes seizures. Then coming to chlorprocaine, one point, like it is ester, it is the shortest acting local anesthetic, and duration of action is 15 to 25 minutes. It is shortest acting local anesthetic. It is most acidic, most neurotoxic. Neurotoxicity is due to presence of sodium metabisulfite as its preservative, and it is contraindicated in spinal anesthesia. Chlorprocaine is contraindicated in spinal anesthesia. Then coming to procaine, nothing much. It is a duration of action of 25 to 35 minutes. Again, it's metabolism by esterases. We are not using procaine now, just forget about this. Then coming to prilocaine. Prilocaine, it is intermediate acting. Metabolism is by amidases, both liver and also in the lung. Safest local anesthetic used in hepatic failure, and it can be used in Beer's block. We'll discuss in Beer's block in next 15-20 minutes, Beer's block. And what are the side effects of this? What are the side effects of Beer's block? It predominantly causes, come on guys. Prilocaine, once if you say like prilocaine, it should strike. Prilocaine, what is the side effect of prilocaine? Everyone, please type in the chat box. Come on, come on. Yes, very good. It is methemoglobinemia. Due to its metabolite orthotoluidine, which converts hemoglobin to methemoglobin. Then coming to most important drug, the two drugs which we have to remember very particularly, lidocaine and lidocaine or lignocaine and bupivacaine. Coming to lidocaine, most commonly used local anesthetic drug, also known as lignocaine. It has preservative methyl paraben. And it is contraindicated in spinal anesthesia. Preservative-free drug is called as xylocaine, used as anti-arrhythmic drug. It has side effects of neurotoxicity. This anti-arrhythmic drug. Preservative-free xylocaine is used as an anti-arrhythmic drug, and also please note down, it is used to blunt the intubation reflex. Blunt the intubation reflex. Is to blunt the intubation reflex. Then it is available in various formulations. 0.5% heavy is used for. Come on, guys. 0.5% IV is used for. Starts with B. Intravenous regional anesthesia, IVRA, that is Beer's block. 1 to 2% is used for. 1 to 2% is used for epidural. 2% jelly is used for urethral procedures, and even this epidural and also for peripheral nerve blocks. 5% jelly is used for 5% heavy. When I say heavy, it is addition of dextrose. We'll discuss the addition of dextrose to make this hyperbaric. Is used in spinal anesthesia. Both 4% and 10% are used for topical sprays. And the maximum safe dose of lignocaine without adrenaline is 4.5 mg per kg, and with adrenaline it is 7 mg per kg. And duration of action, come on guys, it is 40 to 60 minutes. It is 2 to 3 hours. And the 70 kg person, an average 300 mg is what you can do maximum here, and close to 530 mg is maximum what you can use it here. Okay, if they ask based on kilograms, an average adult. Then coming to bupivacaine, it is long acting. It is 8 times more potent than lignocaine. Most commonly used drug nowadays for spinal anesthesia and labor analgesia. And the characteristic of this is differential blockade. Differential blockade. Differential blockade in the sense at certain concentrations it blocks it affects at higher doses it blocks entire motor and sensory, but in lower doses it blocks only the sensory component. Higher doses has both sensory and motor effect. Lower doses only sensory. And remember, bupivacaine is the most cardiotoxic drugs, and it causes arrhythmias. The most commonly caused arrhythmias are ventricular arrhythmias, it's contraindicated in Beer's block. What is the treatment for bupivacaine-induced arrhythmias? Amiodarone, procainamide, and bretylium. Amiodarone, procainamide, and bretylium. If they ask specifically, then go for amiodarone. And this was the question which was asked in recent INI-CET examination. What is the treatment for bupivacaine-induced cardiotoxicity? I keep repeating in the class. It is 20% intralipid formulation. 20% intralipid formulation. Very, very, very important. We'll discuss again further about this in local anesthetic toxicity. And then coming to this, 0.5% drug, where do you use? Epidural, various formulations. 0.5%, where do you use? Come on, guys. 0.5%, where do you use? It is again for peripheral nerve blocks. 0.5% heavy. Use it for spinal anesthesia. 0.125 to 0.5% used for epidural anesthesia, 0.0675 to 0.125% used for labor analgesia. Labor analgesia. Then, what is the maximum safe dose of bupivacaine without adrenaline and with adrenaline? Come on. Without adrenaline, what is the maximum safe dose? You recollect. See, we are not again going to repeat each and everything. So it's basically a revision class. Come on, guys. 2.5 mg per kg, and here it is 3 mg per kg, and duration of action is 2 to 3 hours here, and 3 to 5 hours here. Then, coming to ropivacaine. Ropivacaine is less potent than bupivacaine, less cardiotoxicity and CNS toxicity than bupivacaine. It also causes vasoconstriction, and maximum safe dose is 3 mg per kg. And God forbid, if there is a cardiac arrest, it is easy to revive when compared with the bupivacaine. Okay, and it is preferred for post-op analgesia and painless labor. Then bupivacaine, longest acting, most toxic, most potent. And where else you heard about something called bupivacaine number? Used to measure the activity of pseudocholinesterases. Then coming to EMLA, the full form is eutectic mixture of local anesthesia, what is the composition? Very, very, very important. What is the composition? Very, very, very. What is the percentages of lignocaine and prolactin? Composition is lignocaine and prolactin. What is the percentages? 2.5% lignocaine and 2.5% prolactin. Onset of action, it is slow. It takes 30 to 60 minutes. What is the uses of this? For for cannulation in children to antagonize the needle phobia. For IV cannulation in children to antagonize needle phobia. What are the contraindications? In the cut skins or in cut mucosa, you can't use this. Then coming to local anesthetic toxicity, what is the first? CNS is the first symptom to involve. Initially, it causes excitatory symptoms followed by CNS depression. What is the reason for the reason why CNS is first involved? I mean, first initially excitatory symptoms, because inhibitory neurons are more sensitive. Inhibitory neurons being more sensitive, they are blocked first. And signs and symptoms, you get like paresthesias, convulsions, numbness, etc. But the most common first presentation is convulsions. You treat with maintaining the airway. And you give benzodiazepines. Okay. Then coming to CVS, it is the most cardiotoxic drug is bupivacaine. Most common arrhythmias are ventricular arrhythmias. Very specifically, idioventricular rhythms with broad QRS complexes. As we discussed, the treatment for bupivacaine-induced arrhythmias is amiodarone, procainamide, and bretylium. The treatment for bupivacaine-induced cardiotoxicity, very, 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 very important. Come on, guys. Type in the chat box. It is good. 20% intralipid formulation. They won't ask the dose. It is usually like 4 ml per kg followed by, not mg, 4 ml per kg followed by infusion. Okay. And this is again And a very important point, cardiopulmonary resuscitation post-bupivacaine is very difficult to revive. Okay, even if you follow the proper ADLS protocols, the chances of you reviving the patient is very less. You have to remember, cardiopulmonary resuscitation post-bupivacaine toxicity is very difficult to revive. Then methemoglobinemia, the drugs which cause maximum methemoglobinemia, you have to remember just one thing, prilocaine, because of its metabolite orthotoluidine, which converts hemoglobin to methemoglobin. What is the treatment? What is the treatment of methemoglobinemia? What is the treatment? IV methylene blue. What does IV methylene blue does? It converts methemoglobin back to hemoglobin. And miscellaneous, like few things, like cardiac syndrome is caused in conditions of tetracaine and lignocaine, so we are not using nowadays. And the myotoxicity. Maximum myotoxicity is seen with, come on guys, maximum myotoxicity is seen with, then the same. Clear? Okay, this is what you have to remember. And one extra point, EMLA, what we are using, we can't use it for cuts and abrasions. There is something called ELA max, eutectic local anesthetic mixture max, a liposomal formulation of lidocaine useful for cuts and abrasions. So if they mention EMLA, you can't use for cuts. These are recent updates. ELA max, you can use for cuts and abrasions also. Okay. Then, what is the most common used drugs for topical anesthesia? You say lidocaine, benzocaine, tetracaine, and ibuprofen. And remember this another extra point. If you can remember, please remember, Cinera is a combination of lidocaine and tetracaine with a heating component. Because of its heating component, has rapid onset and it evokes the vasodilation. What are the local anesthetics that can be used through cut skin? If they ask TAC and lead, what is TAC? TAC is tetracaine, adrenaline, and cocaine. What is lead? Lidocaine, epinephrine, and tetracaine. Tumescent anesthesia means the technique of local anesthetic used during liposuction, where you inject lots of local anesthetic and keep doing it. This is tumescent anesthesia. Now tell me, what is the local anesthetic drug with antiarrhythmic potential? Antiarrhythmic potential starts with L. It is lignocaine in the form of xylocaine. With arithmetic potential, it is bupivacaine. Ignore about this. Articaine is the amide local anesthetic for dental nerve blocks. Okay, TAC and lead we mentioned use it for use for cut skin. TAC is tetracaine, adrenaline, and cocaine. Lead is lignocaine, epinephrine, and tetracaine. Okay, we'll quickly try to answer a few questions. Lignocaine, all are true except it acts on sodium channels in both active and inactive state. It is the most cardiotoxic local anesthetic. It is given IV in cardiac arrhythmias, extensive first pass metabolism. Even if you don't know majority of the things, you can still go ahead and answer. Except, you know, like bupivacaine is the most cardiotoxic local anesthetic. So the answer is B. Which of the following E's are used in bupivacaine toxicity? This was a PGI question. Calcium chloride, betelium, intralipids, esmolol, epinephrine. If it is a direct question like AIMS or INI-CET, like it is AIMS or NEET, straightforward question, intralipids. In conditions of, if they mention they may cause metabolic acidosis, betelium, if they extend the question, you can use the betelium and calcium chloride. Which of the following is correct statement regarding mechanism of local anesthetic drugs? Blockage of resting sodium channel more is than activated sodium channel. Faster conducting fibers are blocked easily. Block sodium potassium ATPase channel. Fine touch goes before pain. In regional block, IV injection is used. Fast conducting fibers are blocked easily because of the myelin. True. Block sodium potassium ATPase channel. Then fine touch goes before pain. They didn't mention about the central neuraxial blockade. It is peripheral. Peripheral pain goes before touch. In regional block, IV injection is used. Will you use? Unless until it is IV regional anesthesia. The answer is B and C. Then anesthetic agent with vasoconstrictor action is contraindicated in. Finger block. Okay. And even in conditions of penile block and ear lobule block. Sodium bicarbonate when given with local anesthetic has which of the following effects? It increases, very good. It increases the speed and quality of anesthesia. So what is the shortest acting local anesthetic drug here? Among the following. Usually if it is available, chlorprocaine is the right answer. If it's, then it is, the next best is procaine. Very good. Maximum dose of lignocaine with adrenaline is, it is 7 mg. 4.5 is without adrenaline. And for bupi it is 2.5 and 3 mg. It is without and this is with adrenaline. Okay, now I'll give you quickly 3 minutes to consolidate this. Your time starts now. More minutes. Please consolidate here. These are all the 3 minutes you have before your March 12th examination. A minute more. Okay, then we'll quickly go to regional anesthesia. A regional anesthesia means you are blocking a particular region. It is basically classified into central neuraxial blockade, and peripheral nerve blocks. So why do you use nerve blocks? Nerve blocks is usually given for either for regional anesthesia and for acute or chronic pain relief. Then brachial plexus block. After the spinal anesthesia, the most commonly used block in the body is brachial plexus block. It is second most common block after central neuraxial blockage. It is used for upper limb surgeries. What are the 4 approaches? Interscalene, supraclavicular, infraclavicular, and axillary. 4 approaches are interscalene, supraclavicular, infraclavicular, and axillary. What are the complications that can occur when you're going for interscalene? The most common thing which you may encounter is it may cause Horner syndrome, and because of stellate ganglion block, and then supraclavicular, infraclavicular, the chances of hitting the lung, causing pneumothorax. Okay, and if the drug, while you're giving interscalene, if it extends into the C3, it may cause phrenic nerve blockade. Please write down complications: phrenic nerve blockade, Horner syndrome, and may cause pneumothorax. What is the most common approach among all these things? What are the most common approach among interscalene, supraclavicular, infraclavicular? I told you earlier, what is the most common? It is supraclavicular. What are the nerves most commonly spared while you are doing the axillary brake? Because when you are giving punctured axillary, the nerves which escapes are already the musculocutaneous and musculocutaneous, and what is one more? Very important. What are the nerves paired with the axillary block? Musculocutaneous and intercostobrachial. Very good. Then coming to BS block, is also called as intravenous regional anesthesia or IVRA. So I told you, you just apply tonic, S-mark bandage, just squeeze, take an IV cannula, inject the drug, and once the surgery procedure is over, just remove the cannula and remove the tonic. The most vital component here is tourniquet application and functioning. Tourniquet application and functioning. What is the most commonly used drug? It is prilocaine. What are the drugs contraindicated? It is lignocaine plus adrenaline combination, and also the bupivacaine. What are the advantages of this? It is easy, rapid onset, good muscle relaxation. Whatever. 1 second. You sharing this screen? Are you able to see the screen? Are you able to see my screen, guys? Mine. Can you type in the chat box? Are you able to see my screen? Okay, got it now. Ready for this? Good muscle relaxation. What are the disadvantages most commonly? It is the tourniquet discomfort. It can be used only for short duration. Then Accidental tornic deflation leads to severe drug toxicity and death. The contraindicated in Raynaud's disease, sickle cell disease, Raynaud's, sickle cell disease, and scleroderma. Then, what are the blocks of lower limb? Very important. Psoas compartment blocks which nerves? Psoas compartment blocks which nerves? Use it to block. Very good. Lumbar plexus. And fascia iliaca? What is fascia iliaca blocks? F for F, femoral nerve. What is 3-in-1 nerve block? Perivascular. Around, it is called as with the by injecting a drug once you can block the 3 nerves. What are the 3 nerves? What are the 3 nerves? Femoral, obturator, and sciatic. Ankle block, 5 nerves. What are the 5 nerves? Superficial peroneal, deep peroneal, saphenous, sural, and posterior tibial nerve. Okay, very, very, very important. It looks simple, but in the examination, it's very easy to get confused. So please remember these things. Ankle block, superficial peroneal, deep peroneal, saphenous, sural, and posterior tibial. What are the contraindications for peripheral neuroaxial blockade? I had already given coagulopathy, patients on anticoagulants, infection at the site of needle placement, known allergy, and I don't know, like something is happening. 1 second, I'll try to reshare. Okay, so coagulopathy, patients on anticoagulants, infection at the site of needle placement, patient has known allergy, pre-existing neuropathy, all these things are the contraindications for peripheral neuroaxial blockade. Then coming to proper spinal anesthesia, we are going to discuss very important points about spinal anesthesia. We are not going to discuss all the systemic effects. Spinal anesthesia, the level at which spinal cord is. See, this is a very important topic. I want every one of you to be very active and keep typing in the chat box. What is the level at which spinal cord ends in adults? In children, it is in L3. Level at which the local anesthetic is injected into the subarachnoid space, usually L3, L4, and children it is L4 to L5. What are the structures encountered during lumbar puncture? It is skin, subcutaneous tissue. What are the 3 ligaments? Supraspinous, interspinous, and ligamentum flavum. In dura mater and arachnoid membrane. Arachnoid membrane. These are the structures which are pierced. So these are very important. Supraspinous, interspinous, and ligamentum flavum. You have to remember, these are the structures encountered during lumbar puncture. What are the indications? It's as simple as that. All lower limb surgeries. For lower abdomen surgeries, you can remember this, that's fine. What are the positions which we can use? The positions you can use in sitting position, lateral, and also in few conditions like prone, but don't worry about this. We are not practicing this. Okay, then approach, either you can go median, that is median or paramedian. Median or paramedian. What are the needles? See here. Predominantly we use Proti, Whitaker, and Quincke type of needles. Quincke, if you see this, they are named based, they're called as cutting type of needles. And Whitaker and Sprotty, they're called as pencil tip needles. Can you see the pencil tip here? It's just like pencil, but the Quinky, it has a cutting type where it cuts the fibers. Okay, cutting type of needles. It has increased the chance of PDPH. Pencil tip needles, examples are Sprotty and Whitaker. Cutting needles are Quinky. Pencil tip needles, technically difficult. Though they are technically difficult, less chances of PDPH. But coming to the cutting needles, they're technically easy. But because they cut the fibers, increase chances of PDPH, post-dural puncture headache. Post-dural puncture headache. Clear? Then, what is the most commonly used drug? It is bupivacaine 0.5% heavy. No need even to remember other drugs. Remember bupivacaine 0.5% heavy. This heavy or hyperbaric is due to addition of 8% dextrose. So why use, what is the role of hyperbaricity? To fix the effect of the drug. The effect of the drug. Because it keeps flowing in CSF to stop that. Okay. Then, what are the dermatoval levels required for various common surgical procedures? For upper abdominal surgery, you need effect till T4. For cesarean, you need till T4. And TURP, transurethral resection of prostate, till T10. For hip surgeries, you need effect till at least T10. And for foot and ankle surgeries, it is at least till L2. Okay. Now, we are not going to discuss about the factors. This is not very important. Factors affecting blockade, not affecting blockade. What are the systemic effects? We'll straight away go to the complications. Intraoperative complications. The most common intraoperative complication is hypotension. How do you prevent this? In the olden days, they use the preloading. We are not following now. Not recommended now. Preloading is giving IV fluids, loading with more and more of IV fluids. And if at all hypotension occurs, keep the patient in Trendelenburg position, 50 to 25 degrees. Head down, give IV fluids, vasopressors, and inotropes. Then coming to high spinal and total spinal. If the drug has been given in addition, more volume, or like drug has percolated, if the drug effect won't get fixed, it may cause high spinal and total spinal. High spinal, you call it when it reaches the effect such that it blocks the phrenic nerve. And total spinal, even till the level of cranial nerves. Till the level of cranial nerves. What are the clinical features? It causes hypotension, bradycardia, because respiratory depression. So how do you treat? Simple. IV fluids. For hypotension, you give IV fluids, vasopressors, and inotropes. For bradycardia, atropine. For respiratory depression, what do you use? For respiratory depression, if it is prolonged, you maintain the airway with intubation and needed mechanical ventilation. And other complications like bradycardia, as I said, like you manage with atropine, respiratory depression, maintain the airway. In case intubation plus ventilation, IPPV. Cardiac arrest, follow the ACLS protocol. Anaphylactic reactions, we use adrenaline. Shivering, most commonly use pethidine or tramadol. Coming to complications, what are the most common post-operative complication? What is the most common post-operative complication of spinal anesthesia? Anyone? What is the most common post-operative complication? It is not PDPH, it is urinary retention. Please remember, urinary retention. Cranial nerve, then cranial nerve palsy, the sixth cranial nerve is most common, the abducens, because it has longest intracranial course. Longest intracranial course, and it may cause meningitis. The most common is the organism Streptococcus viridans. It may cause paraplegia due to epidural hematoma, and it may cause backache, cauda-equina syndrome, and PDPH, post-dural puncture headache. We'll discuss about PDPH. The CSF leakage, if you use with the most commonly with cutting needles, the CSF continuous leakage causing low pressure headache. This is a meningovascular headache. Meningovascular. It involves both meningeus and vascular headache. Usual occurrence after spinal anesthesia, usually after 24 to 48 hours. Most common site where it is involved is occipital and occasionally frontal. The posture in which pain worsens predominantly is standing position, standing erect. What are the factors which increase the incidence of PDPH? It is more common in young than old. Gender, it is more common in females than males. Needle size. If you use larger size of the needles, when you say larger size of the needles, that is more gauge, like 21, 22, 23 gauge has more incidence than 24, 25, 26. That is gauge, needle size. If needle size is more, it is more incidence than needle size, less. Okay. Needle type. Cutting type has more incidence than pencil tip type needles. Number of dural punctures. As more and more dural punctures are there, more incidence. And pregnancy, you can see increased incidence of PDPH. How do you prevent this? Use small bore needles. Try to decrease the number of attempts. And needle type. So we use pencil tip needles. What is the treatment? What is the first line of treatment? You give adequate bed rest, lying down supine. Give IV fluids, IV or oral caffeine, and you use analgesics. Won't subside with this. Then the second line of treatment. What do you use? Abdominal binders, carbon dioxide inhalation, triptans, and have you heard of, triptans are there. Have you heard of dietans? DITAM. Recent edition in the 20th edition of Harrison. We'll discuss this later. Third line of treatment. It is autologous, 20th edition of Harrison, I mean to say, not Miller. Autologous epidural blood patch. Datans are used for migraine. Okay, autologous epidural blood patch is the third line of treatment. This is very important about PDPH. Then coming to contraindications. What are the absolute contraindications and relative contraindications? Very, very, very important. The absolute contraindications. Come on, guys. What are the absolute contraindications of spinal anesthesia? Remember, patient refusal is an absolute contraindication. Then patient refusal is very, very, very important. Increased ICP, shock, bleeding disorders, patients on anticoagulants, infections, and intracranial mass. All these are absolute contraindications. What are the relative contraindications? What are the relative contraindications in conditions of? Come on, guys. What are the relative contraindications? Any CNS disorders, psychiatric disorders like kyphoscoliosis, aortic or mitral stenosis, MI, heart blocks. Okay, this is very, very, very important. Contraindications of spinal anesthesia: patient refusal, increased ICP, raised ICP, shock, bleeding disorders, patients and infections, intracranial mass, and relative contraindications with CNS disorders, psychiatric disorders, kyphoscoliosis, aortic and mitral stenosis, MI, and heart blocks. Then coming to epidural anesthesia, you see this is the epidural needle called 2 and this is the channel. This is the epidural catheter what you insert inside after for prolonged epidural anesthesia. You keep injecting the drug through the chamber here. Okay, what are the structures pierced here? Skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, and ligamentum flavum. So that's it. You will give the drug above the arachnoid membrane, that is epidural, above the dura. Okay, above the dura and arachnoid membrane, you give it above the dura. Okay, what the drug is injected between? Where is the drug injected? Okay. Ligamentum flavum and dura mater, above the dura, ligamentum flavum and dura. Most common needle is used is 18 gauge to high. What are the drugs most commonly used? Lignocaine 1 to 2%, bupropion 0.125 to 0.5%, and ropivacaine 2%. What are the techniques used to identify the epidural space? See, the basis for this is the continuation of negative pressure space. Continuation of negative pressure thoracic cavity. So most common method used is LOR technique, loss of resistance. LOR technique. What are the other common methods used? Like there are many things like hanging drop, Duran, Westphal, but if you can remember the hanging drop and loss of resistance, that is more than enough. The indications of epidural anesthesia, you can see all the surgeries done by spinal anesthesia, that is lower abdomen and lower limbs. In addition to this, you can also use for upper abdominal, thoracic, and neck surgeries, and it helps in controlling post-operative pain. You can keep giving the drug for 2 days, 4 days, depending upon how you maintain the catheter, and painless labor for labor analgesia, and also in the case of chronic cancer pain, you can use it. What are the advantages of epidural? Level of block can be altered because the drug is fixed. Depending upon the amount of drug you give, the level of drug block can be altered. Any duration of surgery can be performed unless other than spinal anesthesia. Less hypotension, no chance of post-dural puncture headache because you are not puncturing the dura. And the disadvantages are high chances of high spinal with accidental rupture of dura. If you are not careful and if you puncture the dura with the 18 gauge needle, the high chances of PDPH, and it's slightly technically difficult when compared with the spinal anesthesia, and it is expensive and 120 rupees, and long onset time 15 to 20 minutes, whereas spinal you get the effect very fast. Quickly writing on the differences between spinal and epidural anesthesia. Level, usually L3 to L4 or L4 to L5. Epidural you give at any level. What is the injection site? What is the injection site in spinal? Come on, keep saying it. My internet connection is not stable. One second. Subarachnoid space. Here above the dura. Dura mater puncture present, absent. Needle, it is twinky or sprotty. Here you use 18 gauge to high. Here you use most commonly 26 gauge. What is the dose you use? Here usually you use 3 ml bupropion, 0.5% heavy, Here you use 15 to 25 ml. Okay, here it is. Bupivacaine, 0.5%, that's it, plain. Here it is heavy. How do you identify the space? It is basically free flow of CSF and here epidural LOR technique, loss of resistance. Onset of action in spinal is rapid and it is slow here. Density of block is high in spinal, less in epidural. Hypotension chances are high, epidural less. PDPH chances are more and absent in epidural. It is very simple comparison between spinal and epidural. You may get a question like all of the following are true about spinal anesthesia except vice versa. All of the following are true about epidural except. Then coming to spinal saddle anesthesia. Saddle anesthesia is nothing but spinal anesthesia, which is given in a sitting position. And after giving spinal, ask the patient to remain seated for 5 to 10 minutes at least till the drug effects gets fixed. Use it for perianal or perineal surgeries. Nerve roots involved are usually S2 to S5. Advantages, there won't be any hemodynamic fluctuations are minimal, and there's no possibility of high spinal or total spinal. Then coming to caudal anesthesia, use it primarily for analgesia in children less than 7 years. Use it for perineal and infraumbilical surgeries. The key is identification of the sacral hiatus. Once you identify the sacral hiatus, then you have to identify the posterior superior iliac spine, try to form a triangle and give the drug at the sacral hiatus. What are the structures pierced here? Remember, skin, subcutaneous tissue, and what is the one most important thing? Skin, subcutaneous tissue, and one more thing, which is a continuation of almost ligament of flavor. What is that? It is sacrococcygeal ligament. Sacrococcygeal ligament. Okay, this is about caudal anesthesia. So the recent update, see, cerebrospinal fluid or height, CSF volume, how much is there, and local anesthetic baricity, whether it is hyperbaric or hypobaric or isobaric. Okay. For PDPH, it's a definitive cure. And preservative-free morphine is most widely used hydrophilic opioid in spinal anesthesia. When we discuss about opioids, we'll discuss this. What are the factors to prevent PDPH? Needle bevel. Less when needle bevel is placed on the long axis of neuraxis, but when the needle bevel, when you are inserting, if it is in the long axis of the neuraxial plane, it decreases the PDPH. And modified Bromage scale is used to assess the effect. 0 is no motor blockade. 1 is after giving the spinal. Modified Bromage to assess the effect after spinal anesthesia. To assess effect after spinal anesthesia. 0 is no motor block. 1, inability to rise extended leg, able to move knees and feet. 2, inability to rise extended leg and move knee, but able to move feet. And 3, complete block of motor. No one is going to ask you 0, 1, 2, 3, what is it? But they ask, what is modified Bromage scale? Why is it related? It is to assess the effect of spinal anesthesia. Okay, then we'll quickly answer a few questions. Again, these are important. Celiac plexus block. See, celiac plexus block is located retroperitoneally at the level of L1, formed by celiac plexus block. Celiac plexus is formed by greater and lesser splanchnic nerves of both sides and a part of right vagus. It usually supplies all the GI organs, lower esophagus, liver, and pancreas, usually given in bilateral. Most commonly, it used for CA pancreas. Painful complications of upper abdomen, chronic pancreatitis, and CA pancreas. Once you block the celiac plexus, it may cause diarrhea and hypotension. Okay, this is because of the unopposed parasympathetic action. Celiac plexus is taking care of sympathetic. Once blocked, the parasympathetic action is unblocked, and it may cause diarrhea and hypotension. Then stellate ganglion, also known as cervicothoracic ganglion, and it is in anatomy, fusion of inferior cervical and first thoracic sympathetic ganglia. Here, the landmark to identify is C6 transverse process, Chesignax tubercle. How do you confirm the stellate ganglion block? Horner syndrome, if it is present, it is a sign of successful stellate ganglion block. What are the components of Horner? Ptosis, meiosis, anhydrosis, anophthalmos, and loss of ciliospinal reflex. Then tab block or transverse abdominis plane block. You insert the drug between internal oblique, see external oblique, internal oblique, and transverse abdominis. You administer the drug between internal oblique and transverse abdominis. Okay, and use it for any lower abdominal surgeries. Then, few MCQs. In all of the following conditions, neuraxial blockade is absolutely contraindicated except patient refusion, coagulopathy, severe hypovolemia, pre-existing neurological deficit. It is very good. Pre-existing neurological deficit. It is a relative. Spinal anesthesia is given at which of the following levels? L1, L2, L2, L4, midline of thorax, below L5. Come on, everyone, try to attempt the questions. Yes. It is L2 to L4 or more precise L3 to L4. What is the first fiber could be blocked in spinal anesthesia? Sympathetic preganglionic, afferent motor fibers, sensory fibers, efferent motor fibers. I told it is in central neuraxial blockade, it is autonomic which gets involved first. Then post-lumbar puncture is minimized by all except keep stylet and remove needle, atraumatic needle, small diameter needle, hydration by crystalloid infusion. Atraumatic needle, it decreases. Small diameter needle, it decreases. Hydration by colloid infusion, IV fluids, yes. But keep stylet and just remove the needle. The stylet is still there, it causes pain. So this is the answer. What is the maximum dose of lignocaine with adrenaline for local blocks and ophthalmic surgeries? However the question might be. This lignocaine with adrenaline for local anesthesia, it is 7 mg per kg. True about subarachnoid. Can't be used in children, infant and children. Is a false statement. We can use. Can be given by unskilled doctor. No. May be used when IV access is not possible for IV drugs. Never ever. Whenever IV access is not there, don't attempt spinal anesthesia, because if the patient lands up in high spinal or total spinal, then it's very difficult to manage. Hypotension is the most common side effect intraoperative. Correct. Which of the following are features of epidural anesthesia than spinal? PGI question. Smaller size of needle is used. Is it true? In epidural, you use larger size of needle. Drug is used is less in concentration. Drug used less in concentration. True or false? Less chance of spinal headache. True. Onset of action is delayed. True. Density of anesthetic action is less in epidural than spinal. True. So except A, all are correct. Okay. This is about the spinal anesthesia and epidural anesthesia. Okay. So are you confident about local anesthetics and regional anesthesia? Yes or no? So once after this session, again spend 3 to 5 minutes over the entire regional anesthesia and then just consolidate that, so that there's no need for you to revise till your examination. Okay. And as I keep repeating in every class, the most important thing, take advantage of power naps, social media distraction time, 3 times a day or 4 times a day, and revision. 30 minutes while before you sleep and 30 minutes once you wake up for the previous day topics. Revision, most important thing. The consistency of revising is very important, and learning from mistakes. Try learning from mistakes. Whatever mistakes you make, put it in notes and try consolidating them. This is one very important thing which helps you in your preparation, and doing as many MCQs as possible, guys. Okay. All the very best, and see you in the next session. Have a nice day, guys.